everybody, and welcome to Gender Queries, a podcast about trans and gender diverse healthcare in Atlantic Canada. My name is Jess, and I use they and she pronouns.
I'm AJ, and I use he, they pronouns.
And my name is Sam, and I use they, them pronouns.
Today we wanted to chat about fertility and pregnancy, specifically as it relates to trans and gender diverse folks. First, I just want to cover some of the cultural and political context with this because Canada has a history of both legislated and non-legislated coerced sterilizations. This can be a topic that brings up a lot of emotions for folks. There has been news in the past even 5 years that this practice is ongoing. So for example, in 2021, a Senate committee found that Indigenous women continue to experience forced and coerced sterilization, as well as people living with disabilities, Black women, racialized and ethnic women, and people living with HIV. There was a news story about a doctor in the Northwest Territories who was penalized for forcibly sterilizing an Indigenous woman in 2019. So it's recent and ongoing. The most recent report found that 2S LGBTQ+ folks are no longer targeted for forced sterilization in Canada for sexuality or gender reasons alone, but obviously folks who have intersecting identities might experience that differently. Fertility care is one of the areas of healthcare that is not typically covered fully by provincial healthcare. And a lot of people have written about this and talked about the ethics behind this. But there is an argument for providing reproductive care, including fertility support for trans folks. I just have a quote here that I wanted to read. Just like people who decide to have an abortion because they cannot afford to have a child, despite existing desire for that child, young transgender people should not have to forego the prospect of future children in order to obtain certain hormone therapies and gender-confirming surgeries to alleviate their gender dysphoria. So basically, especially for young folks, maybe you can't afford assisted reproductive therapy or fertility preservation before you want to get your gender-affirming care, but that shouldn't have to be the case. You shouldn't not have that option. Obviously, that still happens, and we'll get into it a bit. Even though, in theory, you would think that this applies to anybody who doesn't have the gametes required to make a baby if they want one. You would hope that everybody would have access to that. The majority of assisted reproductive therapy in Canada is privatized. And our system apparently also doesn't record much data, including patient sexuality, gender, class, etc., when it comes to those who use assistive reproductive technology, so we don't actually know who is and isn't being excluded on a national level. I'm joined by Dr. Heather Cockwell.
I'm one of the 4 gynecologic, reproductive endocrinology, and infertility specialists in the province. We mainly deal with infertility. I have a special interest in 2S LGBTQIA care. I am one of the 2 physicians who runs the gender affirmation clinic at the IWK. And I do a lot of the gender-affirming surgeries and also gender-affirming counseling with respect to fertility options, both pre- and post-surgery. And I see a wide variety of individuals and couples with all sorts of different gametes and uteruses and all sorts of things mixed in together. And then we basically talk as a group with the patients about what their options are and if they want to get pregnant, how they can.
I know some of that you're doing out of the IWK, some of that you're doing out of the fertility clinic. Mm-hmm. How does that all work?
The fertility clinic is off-site from the IWK because fertility treatments themselves are not covered by MSI. So you can't do a fertility type procedure like IVF or intrauterine insemination in a government-funded building. So that's why the clinic's off-site. But the services such as counseling and initial workup and that sort of stuff is covered by MSI. So it's a really interesting mix of what we do have covered and what we don't have covered. And everything I do at the IWK is covered. So my gender affirmation clinic is at the IWK. I operate out of the IWK. That stuff is all covered by MSI.
Do you find that there are barriers that trans and gender diverse folks might encounter when trying to access that fertility care?
The biggest barrier that's kind of an ongoing issue is finances because things aren't covered. There are a lot of extra steps depending on what gametes an individual comes to me with and whether or not they have a uterus. They may be looking at donor gametes, they may be looking at gestational carrier. Donor gametes are not cheap, so that adds in an extra step. And then once they enter into treatment, so like for instance, an individual, or if I have 2 individuals who both have eggs and uteruses and I don't have sperm involved, if they're going to use a donor sperm, they then need to pay for intrauterine insemination. That's not covered by MSI. So there's those kinds of costs. And then there's also, I think, a bit of a perceived barrier with respect to healthcare in general with our 2S LGBTQI population. We've really done a lot of work to try and break that down at the clinic and be very open and accepting. We've pushed all the changes that needed to be done, like making gender-neutral bathrooms. We have gender-neutral paperwork. You can choose when you come to the ART which paperwork fits best for you. And we right away ask people, what are your pronouns? What do you want to be called? And we also ask, sexual orientation. And we're trying to be very, upfront about, like, give me all the information you can, and I will call you what you want to be called, obviously. Use your pronouns that you want me to use, obviously. But I have heard in the past that there's been some concerns about that, but I think that's improved a lot.
I think there's a perception that trans people don't want kids. Do we know what % of the trans population wants kids, or?
Yeah, like how many trans people want to parent and how many want biological children. I was able to speak with a researcher who does focus on the social side of this.
I'm Dr. Elgin Pecjak. I hold a PhD in Feminist and Gender Studies from the Institute of Feminist and Gender Studies. My background is in reproductive technology use, fertility preservation, and desires for biogenetic parenthood among trans and non-binary folks. I do a lot of work with different committees, so I'm on the CFAS 2S LGBTQIA+ special interest group. I work with Mount Sinai Fertility Clinic on some of their groups as well. I'm also working with Mount Sinai Hospital on one of their parent and family advisory councils. And I generally just really enjoy talking about disparities in healthcare that our community members face. I myself am a trans man who's queer and poly, and so it's very important for me to talk about the different intersections of different lived experience when it comes to what is it that our community is looking for and what does our community need in terms of access to parenting and overall reproductive and sexual justice health work.
Do we have an idea of how many trans and gender diverse folks are interested in parenting and how many are interested in potentially having biological children as well?
Canada was the first country to do the statistics about how many trans and gender diverse identifying folks there are in Canada. That's about all we got. When it comes to talking about trans and gender diverse folks who want to parent, it's very complicated because we have a set of different lived experiences. So number one, you have folks that parented before they discovered and came out openly as transgender, gender diverse. You have folks that are non-binary who find navigating the system a lot easier, or trans folks who are like, I want to closet myself for protection at this point because I don't want to have to go through the difficulties of trying to become a parent as a trans person. And then you do have folks that are very openly trans and very openly non-binary and do parent. How many folks want to become biological parents is a very different thing. This is actually what I did my entire dissertation on. You use the term biogenetic. Reason being, biogenetic means there's genetic connection between parent and child. In very cis-normative, heteronormative societies like ours, that biogenetic connection is gold. We want our children to be biogenetically connected to us. Patriarchy is based on biogenetic connection. So what I so much found was that trans and gender diverse folks were actually less interested in biogenetic parenthood and more interested in just being parents. So what does that look like? It's quite a bit different. So there are, of course, folks that are like, I really want the experience of being a biogenetic parent where I freeze my eggs, freeze my sperm, or folks can be like, I want to experience pregnancy, or I want to have a partner that we can become pregnant together. But ultimately, we have no idea because we've done the basics of being like, oh, there are trans and non-binary folks in Canada. We still don't have accurate representations of the number of intersex folks we have in Canada, the number of two-spirit folks we have in Canada. When we have so little to work with, it's very difficult to be like, okay, this is the number of trans people that want to become parent. So we have no actual concrete statistics about what that looks like.
Do you know how many trans and gender diverse folks are even having conversations about or even able to consider access to fertility treatment?
So there's conversations going on between trans and non-binary folks. There's conversations happening at the social work level when people are transitioning medically, at the doctor's offices, and then there is the clinical-based conversations. In my own research, I found I tend to work with trans masculine folks, non-binary folks, and trans men. Of those folks that I spoke with, many of them had no idea what fertility preservation looked like. Many of them had had conversations and had desires for social-based parenthood, but really didn't know much about biogenetic parenthood. There were a couple exceptions, of course. But generally, trans and non-binary folks have to become our own encyclopedias of healthcare. So while there are a few conversations going on in like a healthcare atmosphere, and those can vary from, folks are not told at all about fertility preservation to I just got a new family doctor who's amazing. And she's like, okay, let's talk about family building. Let's talk about fertility. So I've been asked 4 times throughout my medical transition in the last 6 or so years. So we have these varied experiences, which makes it very difficult because we have no idea who is actually being talked to. And if there is a particular reason, so is it geographic location? Is it I went to a gender clinic? If you go to a gender clinic, you're probably going to get a much more trans-affirming experience than perhaps, going to your family doctor who may not necessarily even know about fertility preservation. That's the other really, really difficult thing, is that many healthcare providers have absolutely no idea. For a long time, it was the assumption once you start your medical transition, if that's what you choose, they just assume you're going to be infertile. The really, really cool discovery in my research that I'm like super, super excited about, and it went totally different than I thought, is that people were very interested in being parents. 70 or 80% of my participants wanted to have kids. They wanted to be parents, or they wanted to foster, or they wanted to be mentors. What ends up happening is you have a large collective of people that want to parent, want to mentor, want to foster, but there's still so many systemic and institutional barriers to that. So for instance, when we talk about the cost of fertility preservation, I also had someone who was chatting with me and was talking about having to go through the legal system of adoption, having to have home visits, which is incredibly discouraging for some trans and non-binary folks because many of us understand the anxiety of having to perform gender in a very specific way. And so fertility treatments are great because technically they cannot say no to becoming a parent. However, the way that the medical system works, it's very difficult for trans and non-binary folks to get affirming healthcare that makes us want to go to fertility clinics. And then on the flip side, when it comes to social forms of parenthood, it's also very, very difficult for us to create formal forms of family that are socially based because we're also worried about cisnormativity, heteronormativity, different forms of discrimination that our communities commonly face, especially given how underemployed trans and non-binary people continue to be. I know members of the queer community are like, I want to be a parent, but it's just me and I'm a queer man, so can I adopt on my own? I ultimately ended up discovering that yes, fertility preservation and fertility counseling are a big issue because the access isn't there. But what I came to realize is that regardless of the path that trans and non-binary folks take when it comes to parenthood, it is a minefield.
Based on a study by TAM in 2021, up to 25% of fertility clinic users in urban areas of Canada identify as LGBTQ+, but it's unclear how many of them are specifically trans and gender diverse. And many trans people, often over 50% in certain studies, either want biological children or would have strongly considered or undergone fertility preservation if offered. But this desire is less pronounced among trans youth. There's still a desire for biological children. Actually, around 1/3 of trans youth in a 2018 study mentioned a desire for biological children. But there's more youth who just either haven't thought about that or think that they don't want children. In one study, trans adults' desires to have children was correlated with their willingness to pause hormone therapy if necessary. So there are lots of folks who would be willing to do that in order to have a biological child. However, even though there does seem to be a desire, rates of fertility preservation use among adolescents tend to be very low. One study had 2 out of 72 participants use it. Another study had less than 5%, despite fertility counseling. Some of the barriers mentioned included that they may have to delay starting hormones initially. They might have some discomfort with producing gametes. So, for example, if you need to preserve sperm, if that causes dysphoria for you, that might not be something you want to do. Or they just have a very difficult time envisioning parenthood. If you're a youth and you're faced with a possibility of transitioning, you might not want to pause any of that. What elements of physical transition can impact fertility?
The biggest one is the puberty blockers. So rewind 10, 15 years when I was early into my career, we weren't giving puberty blockers very much. Very rare were we ever giving puberty blockers to kids. And so we don't actually have a lot of data on what to do with these people when they then hit puberty, want to have children in their 20s and 30s. More recently, we're seeing more and more people going on them. The tricky thing is if I have a kid who's 10 years old and they go on a puberty blocker, prevent puberty because of their gender dysphoria, perfectly appropriate, and then they come and see me at like 14 or 15 and they're now going to go on their gender affirmation hormones, they've never gone through any sort of maturation of their gametes. We've shut down the testes or the ovaries or whichever they have. So I can't get mature eggs from them or mature sperm from them. So I don't have any fertility tissue that I can actually access for them. So what's really interesting is now in the literature, we're starting to see these articles coming out about like, well, what do you do with this person? And there's like these studies looking at, well, if I get testicular tissue or ovarian tissue from these individuals, can I mature these immature gametes that are still there, but very immature? Can I mature them? And so far the answer has been no. So it's really, really tricky because now at this point in time, if someone comes to me who's been on puberty blockers for 5 years, they want to use their gametes, they have to come off of their puberty blockers, stop their gender affirmation hormones, go through puberty, which is not like something someone with gender dysphoria wants to do, right? Because it's the opposite puberty that they want. And then when I have mature eggs or sperm, I can get them from them. And that's just not feasible for a lot of them. We've shifted now towards more of, well, you might need to use donor eggs unless you're willing to do this. Previously, I was dealing with individuals who were trans who had often gone through their cisgendered puberty that they didn't like, and then they went into transition later. So their gametes did mature. Yes, they transitioned, but now because I have mature gametes, I have more access to them. So it was easier before, but now we're struggling. The other thing that people should know and do, most if they're on hormone therapy, they do know, is that the hormone therapies affect their fertility. So if you are a trans woman and you go on anti-androgens and estrogens, you will shut down spermatogenesis, which for a lot of people is just fine. They don't care about it, right? But I can't get sperm from that individual unless they come off of their anti-androgens and their estrogens, and they're going to lose some of their feminization in that process. Interestingly, we used to say the exact same thing about trans men. You have to come off of your drugs until your periods resume. But now there's actually emerging evidence that we don't have to do that. So my counseling in the last year, it's very new stuff, has changed that maybe you don't need to come off the drugs, or maybe we can just decrease your dose a little bit, and I can still run your cycle without you actually having to lose your masculinization. It's an evolving field, partly because there are more and more people identifying as gender diverse, and partly because I think previously a lot of these people transitioned later in life when they had either completed their childbearing or they had decided they didn't want to. So they weren't really seeing us as much. And so now we're seeing more of people who are very young, like I've seen a 6-year-old, to counsel the parents about futures. But because we're seeing more people who are young, there's more discussion about what does future fertility hold for them.
What is that side of it like, talking to the parents, and the kid's probably not super interested in that conversation?
Yeah, it's really hard, but I think it is important because in that situation, the 6-year-old kid, the parents are making the decision about puberty blockers. The 6-year-old's expressing their desire and their wishes, but really the parents are the ones who are going to be like, yes, okay, we're going to let you do this, with lots of counseling about why this is important and that sort of thing to the parents. And then I think part of that counseling with parents, when I've had that conversation with them, is that they are concerned that if they make the decision to put their kid on gender affirmation puberty blocking, they are making a decision now that's going to affect their kid's fertility in the future. And so they need to have that conversation with me to be like, okay, this is what the future will hold for your kid, and this is what we know right now. This may change in 5 years. Like, your kid's only 6. Give me 20 years. This may be a completely different discussion, and I might be telling you something completely different, but this is what we know right now. So it's hard because, I'm a parent, I have 2 kids, and making medical decisions about them always falls on my shoulders because my husband is not medical. And so there's always that, like, what is best for my child kind of discussion. And the kid has some choice too, obviously, but you still have to be able to, at the end of the day, be responsible for it.
So what are the options that folks have for fertility preservation?
If I see somebody who has not been on puberty blockers and they've entered into puberty and now they're thinking about saving their gametes, then for a person with ovaries, you can cryopreserve either eggs, oocytes, or you can cryopreserve embryos. The tricky thing about cryopreserving embryos is I need sperm to make them. So either they need to be with a partner who they are going to stay with, because if I make embryos with that individual who has sperm, and then later on they break up, those embryos are their joint custody. So one of them cannot come back and use them without the other person. So you have to be pretty sure about the person you're making embryos with. If it's your life partner, great. If you've just met the person, maybe not. You can also use donor sperm to make embryos. Or you can just freeze eggs. Optimally, we would do that before they're too far into their transition. And it is part of the discussion prior to going on gender affirmation hormones. They have a discussion about fertility options and like, do you want to do this? I think a lot of the time people are younger, like 14, 15 going on it. They're like, I don't want to have kids ever. So, and then they come back to me like 10 years later and like, hey, wait a minute. So then we have another discussion. With respect to the person who makes sperm, we need to do that before they go on their anti-androgens, because that'll suppress spermatogenesis, but also the longer you are on an anti-androgen and estrogen therapy for gender affirmation, the more your spermatogenesis is suppressed, and it can be irreversible. So I have had individuals who have been on it for 5 years, 10 years, and then they do come off of it, and then they just don't resume spermatogenesis. So they never make sperm again. That's frustrating because they'll come off of their anti-androgen and their estrogen for 3 months. They'll do a test, no sperm. We'll wait another couple of months, no sperm. Meanwhile, they're losing their feminization. And so at some point we have to say, okay, well, do you want to keep doing this? Do you want to wait another 3 months? Most of the time they don't. Or do we want to say that's that? So we warn them ahead of time. And I make them do semen analysis to see, is there sperm there before they pay to bank? Because banking's not covered either. Either egg or embryo crowd. So they don't want to jump into banking if there's not enough sperm there to make it worth their while. We've actually started doing testicular tissue cryopreservation at the ART with the belief, because they're much further along with that research, that we're going to be able to figure out how to get mature gametes from that in the future. The difference between that and ovarian tissue cryo is that with a sperm, if I can mature it just to a spermatid, I can inject it into an egg and make an embryo out of it. With an immature egg, an egg has to go through 2 phases of meiosis before it's going to be accepting of a sperm. So if I've got an immature egg, I somehow have to drive it through meiosis, and that's what they haven't figured out yet. Sperm, once they're spermatids, they've already gone through their 2 phases of meiosis. So we do testicular tissue cryo, but we still haven't actually used any of it yet. The protocols are very, very new.
So it's almost a bit of a gamble on future research.
Yeah, it's a constantly evolving field, which is kind of what makes it an interesting field. Right? Because what I know now is different from what I knew 2 years ago. It's different sometimes from what I knew 6 months ago. I do gender affirmation surgery for people who have uteruses. I do not do gender affirmation surgery for people who have like a penis and testes, because that's not my wheelhouse. I know what gets done, but I don't do it. But the important thing about all of that is that when you're doing surgery like that, it is definitive. If you're thinking fertility, you've got to deal with it before you do the surgery. Again, I'm doing surgery a lot of the time on relatively young individuals. Most of the people who come to me for a gender affirmation hysterectomy, they're in their early 20s. And they're saying to me, no, I'm done. I don't want this thing. I'm never going to use it. And by the way, take my ovaries out at the same time because I don't want them either. And I'm saying, well, if I remove them, you're really certain, right, that you don't want to use these in the future because once they're out, they're done, right? And a lot of time people are like, yeah, no, I don't want them. And I'm like, okay, you're consenting for this. I'm giving you all the risks and the benefits. But I still worry that sort of 5-10 years from now, they'll look back and be like, oh, I should have done something first. But when I have that conversation, okay, like if you want to do something, say cryopreservation, and I say to them, but it's not covered by MSI, and incidentally, it's going to cost like $6,000 to $10,000. These are people in their early 20s. They don't have disposable income like that to do that with. So I feel like sometimes they're almost, pushed is not the right word, and coerced isn't the right word, but it's almost like that, to take their ovaries out because they don't want them, but they can't afford to do the cryo ahead of time. So I have some people who choose to leave them in, and I'm like, okay, great choice, because then I can use them in the future. But if they really don't want them, then I'll take them out. But I just worry that in the future they'll regret the choice. Sometimes people who are transmasc or who are non-binary, they don't want to stay on their testosterone for the rest of their life. So they'll use their testosterone treatment until they get to the kind of androgynous state that they want to live their life in. But they don't want to go further into like staying on the testosterone, having more hair growth and that sort of thing. They're happy in this not fully, I have a wicked good beard and lots of body hair kind of state, but more of a like where I want to be. If I've taken their ovaries out when they stop their testosterone, they have no hormone in their body. And so they're going to start having the risk of things like osteopenia and osteoporosis. If I've left their ovaries in at that point, usually they don't refeminize very much. They usually kind of stick where they are, or they can get away with a much lower dose of their testosterone than they would be on otherwise. And then they just kind of live their lives that way, and they don't have to worry about their bones quite as much. If I have someone who's like absolutely trans man, is going to be on high dose androgens for the rest of their life, that's actually better for their bones than their ovaries ever would be. So, yeah, great. We'll take your ovaries out.
For folks who have testes, I found one study that said that there tend to be lower rates of masturbation, and it might affect sperm quality, but we don't know.
For some folks who might have significant dysphoria and have difficulty psychologically when it comes to masturbation, do they have any means of being able to preserve sperm for those folks?
Testicular sperm extraction is an option. It's more invasive, but anybody who has some sort of a psychological block to masturbation, that is an option for them. If you are someone who can produce eggs, we know testosterone therapy induces amenorrhea by suppressing ovulation, and we know that the testosterone can be a teratogen. So how does this all play out when it comes to fertility? Based on the research so far, prior testosterone use does not necessarily lead to infertility, but we need larger studies, and we need more studies that include people who may not have success afterwards, because we have some studies on people who are pregnant, for example. Well, that means that they had some success. So we need to know how many people are not having success if they stop their testosterone and try to get pregnant, and that's just not a population that we have a lot of studies on. There are a few case studies that show successful oocyte retrieval, fertilization, and embryo transfer to a partner, and then live birth, all without stopping testosterone, as well as successful cryopreservation of oocytes without stopping testosterone. So there are case studies. We don't have good data on it, and we don't have good data on rates of success, but we know that it's possible, which could be promising for folks who may have an interest in doing that. Plus, if you have a uterus and ovaries and you are taking testosterone, there's always the option of stopping testosterone temporarily and conceiving using your method of choice. Is there anything that you wish family doctors knew?
I think that they should send us these patients early, because it's always good to have the information. It's good to have a conversation about it. I mean, we do talk to everybody who's thinking about doing gender affirmation hormones. What do you think about having kids? 9 times out of 10, and this happens in the surgery side too, 9 times out of 10 people are like, no, I don't want to do that. But I think it's still worth having a well, do you want to hear your options kind of conversation. At a later date, if you change your mind, then at least you've known those options. But you also have that point of contact too, right? So they can always come back to us.
And those conversations are covered, right?
Yes. So they didn't used to be, but now they are covered by MSI.
We've been talking a lot about what options people have and what is possible, but what do we know about what it's actually like for a trans person to go through this process in our medical system and all the different things that would make this challenging beyond the physiology?
There are some barriers to care for trans folks who are pregnant, and we've talked about some of these before, but they can face social stigma, discrimination, they can face a lack of safe and inclusive healthcare environments, treatment refusal, unprofessional behavior from clinicians, misgendering, all of that. You may experience that anytime you're trying to access a gendered aspect of healthcare. It's really interesting. In terms of dysphoria, some folks say that they feel comfortable in their bodies during pregnancy, but there are others that report worsened gender dysphoria. Sometimes there may not be internal dysphoria, but there is from the assumptions and language of others, especially when there's increased mammary tissue. Maybe now this changes their ability to pass. And they may have some difficulty finding maternity clothes. But what we know from what studies we have, it seems like experiences of the gender dysphoria during pregnancy vary widely. There was just one study that noted that some patients reported that because top surgery lessened their dysphoria, it actually allowed them to consider pregnancy in a way they hadn't previously. So it's interesting how gender-affirming care just gives folks so much more space to think about other things in their life besides the immediate discomfort that they're facing every day. One study found that trans folks were more likely to use non-physician providers and non-hospital birth locations than the general public, so using services such as midwives was a little bit more common. There was also a lot of variation in terms of disclosing or not disclosing their gender identity to healthcare providers, although sometimes pregnancy may also force folks to out themselves in contexts where they were not previously out. So there's just a wide range of experiences. We can't assume someone's comfort level. We can't assume what their experience has been like. I was able to chat with Forrest Sandifer about his experience.
My name is Forrest Sandifer from St. John's, Newfoundland, and I'm 28 years old. Getting pregnant was never, ever a thought in my head, not even for a second, because I've been on testosterone for over 10 years now. So I was with my partner for a very short amount of time. And then I found out that I was pregnant when I was 6 months pregnant. So I had no inkling that I was because I didn't think it was possible for me. I went to my doctor after I was having some like stomach complications, and I thought that I may be allergic to gluten was my first thing that popped in my head. I was like, oh, I'm swelling a little. So I went to my doctor and I had a bunch of blood work done, and everything seemed to be fairly normal besides my, I think it was progesterone, something like that levels. So she thought, first off, from my blood work, that I might have a tumor on my brain that was pressing on one of my glands to create extra estrogen in my body. I was getting ready to start this process to see if I had cancer or not, which was terrifying. But I was like trying to like chill out. I was like, you know what? If I do, I do. If I don't, I don't. I'll figure it out as I go. So I was laying in bed one night with my partner, and I felt something give me a real good kick in my stomach. And I was like, oh, it's either I have an intestine on the run or there's a child in me. I didn't think it was going to be the second option, that's for sure. So I immediately was like, hey, we have to go get a pregnancy test just for fun, just to see. Both of us obviously not thinking that it was going to be positive, but immediately it was. So we're like, okay, let's do another one just to see. Sometimes false positives happen. And we took another one, and it was immediately positive as well. So I called my doctor and I was like, hey, did you think that it was maybe possible that I could have been pregnant? And she was like, no, no. And I was like, well, I think I am. So she immediately got me in for an emergency ultrasound at the hospital here. And the moment the ultrasound tech put the little jelly thing that you like swirl around on your stomach, it was just a face of a baby. And I was like, oh, well, I guess we're doing this now.
It sounds like quite the surprise. You mentioned that you didn't think that this was possible. What did you understand about being on T and the ability to get pregnant?
Before I have the doctor that I have now, I had an older traditional, you're a man, you're a woman. Oh, you used to be a woman and now you're a man kind of doctor. So she had to figure out everything about what it was like to be a trans person because I don't think she had a huge amount of experience. And Newfoundland, we are probably about 5 years behind everywhere else in the world. So what she explained to me was that since I'm on testosterone, that is a form of birth control. So in my head, I was like, okay, that makes sense. Testosterone, less estrogen, no periods. You know, you can't get pregnant without a period. In my head, like apparently. So I didn't think that that was going to be an option for me. I've always wanted kids. I just thought it would go the adoption route. But also being on testosterone, she said eventually it will deteriorate your female organs.
What was it like to navigate that obstetric care as a trans person?
Honestly, I thought that it was going to be terrifying. And I thought that there was going to be looks and little comments and misgendering and all of this stuff happening by healthcare professionals. Because I mean, like, it's not something you see every day. But in my experience, it was perfect. I did not have one moment where I felt uncomfortable. I was spoken to professionally and asked my pronouns, asked how I wanted to handle everything, which was honestly amazing and very surprising. Most nurses and secretaries, while I was waiting to go in to see doctors and stuff, all of them were surprisingly apologetic for like me having to go into like the women's health clinic and a place that is surrounded by the majority of cisgendered women. I did get looks from patients who were there who were also pregnant and wondering why these two gay men are sitting in the waiting area. And then when they call my name, like I'm going to see the doctor because I'm noticeably pregnant at this point. But besides that, yeah, the doctors were great. And like there was one moment where there was a lady who was looking at me who was a patient, and I could tell that the secretary was like giving me the eye, being like, do you want me to like move you somewhere? And I was like, you know what, like I'm comfortable here. I'm not the one who has an issue. Let her work that out by herself. When I was signing all the paperwork after you give birth, the paper says like mother's signature and like father's signature. And this nurse, I swear to God, she's probably been around since like the earth hardened. She was like, you know what? Give me a Sharpie. And she scratched out mother's signature and wrote father's signature. I was like, okay, that is perfect for me, actually. Thank you.
You mentioned that you'd always wanted kids, but you didn't think that it would go this route. Did you find it a dysphoric experience? What was that like for you?
At first, I think I was still in a little bit of shock. I don't know what happened, but the moment I knew, something clicked in my head. And I was like, you know what? This is what you're doing with your body right now. Like, don't think about the fact that you've worked so hard to present yourself in this particular, like, masculine way. And obviously, like, I am not a woman anymore. And all of these things to do with pregnancy are so women based that, like, I had to snap into my head that, like, I am going to feel feelings of dysphoria and that, like, my body is not mine and my body is experiencing something that is typically female, even though I'm living in my man body right now. So there was moments where I would have little panics, just like small short bursts of it, where I'd be like, oh my god, there's a baby inside me. I'm growing someone. But then also while thinking I'm growing someone, that would make me realize, yeah, this is my job right now. And, like, I need to fully focus on this and not really let the anxiety kick in fully. But I'd say the majority of the time, towards almost the end, there was not any moments where I experienced any dysphoria.
What about postpartum?
I'd say that's when the majority of it kind of set in for me because I had time to think about it. So I did have a bit, or quite a bit, of dysphoria postpartum because my body just did not feel like mine.
What has your experience been like as a parent who is trans themselves?
I won't lie, it has been difficult sometimes. I feel like being a parent in general is just an up and down roller coaster of emotions. I did experience extreme postpartum depression, and I know that's extremely common for a lot of people. I'm looking at this child who I love with everything in me, and a part of me is like, oh my God, my life is flashing before my eyes. I can't think straight. I'm looking at you, you're looking at me, like, you need me. You need me to be a parent, and my brain doesn't want to be all the time. I want that to be, like, out there that it's okay to feel like that and, like, you do get past it. Take your time and be, like, so graceful and patient and gentle with yourself. There's no time limit of when it goes away. Ask for help. And just be, like, super proud of yourself that you're going through something that's so hard. There is nothing wrong with feeling like you are the worst parent in the world, even though you're probably not. It's the postpartum. But overall, 10 out of 10 would recommend. I love being a parent. I feel like being a queer parent is so fun because you get to experience everything from a different perspective. It's not all going to be great. You get looks from the older generation mostly. Me and my partner, who's like a big, hairy man, and me, little tiny man with a baby. I've had people come up and be like, so how was the adoption process? Wouldn't be able to tell you. I popped him out myself. And, like, that gets a lot of either laughs or looks. So to anyone who is thinking about becoming pregnant as a trans person, I would have no problems answering any questions from anybody.
Contraception guidelines. Do they vary for patients who are also on gender-affirming hormones?
Yeah. So the contraception guidelines, like if you look at the SOGC or whatever, they're very much written. I mean, the SOGC is a gynecologic organization. So they are very much written towards cisgendered people with ovaries, right? So they're not really thinking very much about my trans patients at all, or my non-binary patients. The important thing to be telling my trans men is that although you may be amenorrheic on your testosterone, it does not mean that you cannot conceive. You can still ovulate. The reason that they're amenorrheic on their testosterone can be because testosterone has a bit of a progestogenic effect in the uterus, makes the lining very thin, so that when they have periods, they're super light. It's like an atrophic lining. So even though they're still having a quote-unquote cycle, menstrual cycle, they're not actually having menses, which is fantastic because most trans men don't want to have a period. Fine. But they can still technically get pregnant. So those individuals still should be contracepting if they have risk of exposure to sperm. Most of the time, those individuals are not really interested in being like the birth control pill, which has estrogen in it, for obvious reasons. So I have a number of patients who will have an IUD, progestin-containing IUD, because then it's done, it's in, and they don't have to think about it, right? That's not something they have to take on a daily basis. I have a couple of patients who have gone for the implant, the progestin-containing implant, or the progestin injection. The corollary to that from the sperm side, Gender affirmation hormones for the anti-androgens, they are very good at suppressing spermatogenesis, but they are still not 100%. And so as you're kind of ramping up with your anti-androgens and your estrogen, you still are making sperm. And so there is still a risk if you are going to put that sperm in somebody who has a uterus's body, then that could make them pregnant, right? So most of the time, individuals in that situation are using the barrier methods, though, or they're counting on their partner's contraception. But it is important that people, especially as they're ramping up their hormones, because sometimes people think as soon as they start their gender affirmation hormones, that's it, they're not going to be able to get pregnant, but that's very much not the case. And you don't really want to have a whoopsie pregnancy when you're on any form of gender affirmation hormones. So,
if someone on testosterone were to get pregnant,
the testosterone itself can have effects on the pregnancy. If the pregnancy is 46XX, which would be assigned female at birth, right? If you're on exogenous testosterone, that little child's external genitalia are going to look either ambiguous, or they may even look like male genitalia, so classic like scrotum and penis kind of thing. It's considered like a teratogen. It's not really a teratogen per se, but it is going to make significant changes. And that has been known to happen and has been known to lead to misgenderification of the child at birth. If the person really didn't intend to be pregnant, they may choose to terminate that pregnancy. But as a trans man accessing pregnancy options, like abortion options, that sort of thing, that's sometimes tricky, right? Because here you are, you're a man going to in Halifax, it's called the Rose Clinic, and people are like, why is a man coming? So now they're outing themselves, which is a little bit hard for some people, because I know a lot of men who live their lives as men, and it's not knowledge anywhere else in the community that they have a uterus. They're not assigned male at birth. And again, I think that's a barrier for them to access care, because they're almost embarrassed to come to us at the Rose Clinic. So they need to be able to call somebody like me that they already know and be like, hey, you know that time we talked about? Yeah, okay, it happened. But the Rose Clinic is lovely and will be 100% accepting of whoever walks through the door. But I think there is that extra step, being a man accessing those services.
I'm going to link a document in the show notes that just has a specific protocol for if you have trans patients who are assigned female at birth and they're not interested in taking a combined hormonal contraceptive. It kind of has an algorithm for an approach to contraception for your trans patients who still have a chance of getting pregnant. Thank you so much for joining us today. As usual, I will link some resources in the description. If you have any questions, you're always welcome to email us or message us. Our email is genderqueriespod@gmail.com, and our Instagram is @genderqueriespod. Thank you so much for joining us.